And I am really excited to welcome to the stage our presenter for today, our panel member for today, Dr. Brittany Lamb, who is a medical doctor and emergency room physician. And I think our discussion today is going to go in a lot of different directions. So, Dr. Lamb, if you want to paging Dr. Lamb, we've got her on the stage here. Brittany, thanks so much for joining us today. And when we met, I think probably in the first 5 minutes, I was like, oh, I've got to have you on one of our discussions because you truly have a perspective that we can all learn from. And so welcome today. And before we dive into the discussion, I know you've got some things that you want to share with our audience. Tell us a little bit about your background and what led to you becoming an emergency room physician.
Yeah. Well, thank you so much for having me, Steve. I'm excited to be here and be part of the community and get the opportunity to speak to people and maybe teach some people some things. So, it's a long journey to get into medical school, and I always knew that I wanted to be a physician. I didn't have anyone in my family that was a doctor. It just kind of was a thing I said when I was a kid, and then I did it. And then in medical school, you're exposed to all different facets of healthcare. And I just was really attracted to the emergency department for a lot of reasons. One, I like to solve problems, and it gives me the opportunity to do that. Two, it's fast paced. I go in there, I do my job, and then I kind of get to disconnect a bit from it outside of the ER, which as I've gotten a little bit older and more experienced, that is a little bit harder to do. But it also affords me the time to be able to get away and to travel. So we have pretty good quality of life in the ER as physicians. So there's lots of reasons, but those are the main ones. And I've been an attending now outside of training for about 5 years. So I was trained in Alabama, and I did medical school. I went to medical school in Florida. I grew up in Florida. So Florida State was where I went. So
Now, what emergency room are you currently working in?
yeah, so I work at Inova Loudoun Hospital, and I'm not here, I should say, like, I'm not here on behalf of Inova. I'm not speaking for them or offering their opinions or anything. I'm just here as a human.
And
uh,
and then we're going to get to it here, but you've got a new sort of service offering that you're
yeah.
offering, again, not affiliated with Innova, that I hope that we can dive into a little bit deeper. And that's helping families who have a loved one with dementia, correct?
Yeah, so I saw this great need. I've noticed it for years, but I feel very passionately that as we age, we should have care that goes in line with our values and preferences. And I think people really struggle to plan for that and to really know how that works on a logistical level. And so for all aging people, this is important, but I've noticed that there's a great need in dementia care because we know that people as they age are at risk of not being able to make their own medical decisions when they get sick in general, but people living with dementia can't do that on a day-to-day at some point. And their family then takes over typically as medical decision maker for them. And it's incredibly stressful and emotional if you do not have a plan. And so I'm teaching people how to create a medical care plan for the person that they're having to make decisions
I
for.
love it. All right. And I know you're gonna give us some tips and tricks and then
Yeah.
also tell us how we can reach out to you here. But before we do that, what I'd love for you to do is to sort of pull back the curtains and give us a glimpse at what life is like from your perspective in an emergency room. And obviously, I mean, most of our audience is related to older adults and, what have you. But quite honestly, I mean, I got two kids and I felt like I lived in the emergency room for a few years there. I think your perspective, what you're about to share, could have probably helped me during that stage in life as well. And quite frankly, There's I think I've read 30% of grandparents are raising grandchildren. So
Mhm.
there's these two generations that are utilizing emergency rooms on a regular basis. But give us a little perspective there.
Yeah, so obviously every ER is different. And I should say, there's different levels of care when you need unexpected or unplanned care. So there's urgent cares, which is different than an emergency department. Then also within the emergency department landscape, there's freestanding emergency departments, and then ERs that are attached to the hospital. And I actually work in both. So we have freestanding emergency departments in Loudoun County that I work at, two of those, and then our main hospital. So depending on what location I'm walking into, and I also before COVID used to work in the pediatric emergency department as well. So as an ER doctor, you have to kind of amp yourself up before you walk in there because you have no idea what is going to happen. Every day is different. Some days I walk in and I can tell as soon as I drive up that things are going to be okay, that it's not chaotic in there. And then other days you walk in the door and immediately people are like, oh my gosh, I'm so glad that you're here. Can you come help me do X, Y, and Z? So it's the problem with the ER is that it's all right. It's not scheduled. It's all unplanned. This is, people having their worst day, people having things that they don't understand happen to them. We're pressed for time. There's little time for really deep discussions and education, which is something that frustrates me, which is why I think I have gone into this space. Because it's hard, if you're having a heart attack, I wish I could sit down and explain to you or your family member, because you probably can't take in any of this information because you're so stressed out, but like what is actually happening to your body and what we're actually doing to care for you. And what really winds up happening is everyone's running around doing all kinds of things and the patient is kind of left there like, what is going on, or their family members. And then at the end, if we can, we kind of tell people what's happening. So it's chaotic, it's fast paced. We have no idea what's going to come in. I'm multitasking. So you may see me sitting at the computer and it may look like I'm not really doing anything, but everything that we do comes from that computer. I'm constantly running a list of who I need to go see, whose labs are back, what orders I need to put in. I'm constantly getting phone calls for consultants, results from patients, like the radiologist will call me and tell me, hey, that person has appendicitis. Then I have to page a surgeon, EKGs put in my face. And then if someone sick comes in, everything stops. So we have to take care of the sickest first. And so when you come to the ER, you should expect to have your entire day sucked away. I think if you have that expectation, you'll be a little bit happier maybe. And just be prepared. If you are bored in the ER, that is good. It is very good if you are bored.
So let's, you alluded to this a little bit in your introduction, but I think it's worthwhile for this point of discussion because a few years back, and I see there's somebody from VHC Health that's on the line. We had an urgent care doctor talking to a group, and his mantra was, I want you all to understand the difference between urgent care and emergency care, because he said some of the frustration that you get when you're sitting around an emergency room for many hours is the fact that you really need urgent care. Do you echo that statement? And can you help us kind of understand if something wrong is happening to us or our loved ones? When should we go to urgent care? When should we go to emergency room care? And when should we call our physician if we have that ability?
Yeah, so I can speak a little bit to that. Obviously, this is a generalization, so
Without a doubt, we've
everybody's
got a big
situation.
asterisk here.
Yeah. So the I will say there is a caveat here. As people get older and they have more complex medical problems, if you go to an urgent care, you are more likely to be referred to an ER if they're not comfortable. So that's one kind of chest pain should in someone who is aging should probably not go to an urgent care. Um, let's see, if you're vomiting or have abdominal pain, probably should not go to an urgent care. I think if you know the question that you're looking to have answered, an urgent care may be appropriate. So do I have flu? Do I have COVID? Do I have, is this broken? And it's not deformed, it's not hanging off. My wrist is not like, blah, I'm bleeding everywhere. Okay. So is there an obvious injury? I think if you're wondering you maybe cracked a rib, you could go to urgent care. It's harder as people get older. It is much harder to know. And so it really does depend on how complex that person's medical history is.
But I really like that. That's a great description, and it somewhat echoes what this doctor said. Is that the emergency room is for emergencies, and an emergency is when something's happening to you and you have no clue what it is. That's a great way. And again, I think this doctor sort of illustrated that's one of the when problems occur, uh, that's one way to sort of help your own experience, but also in general, help Dr. Lamb because you're in the emergency room to take care of these emergencies. And if somebody can be serviced in an urgent care, that means you can devote more time and energy to an emergency. And he also said that, and I'd be curious on your thoughts on this, is that sometimes we go into the emergency room. I think this has happened to all of us, where we're really worried about ourselves or our kids, and we see all these people jumping the line. And it's like, wait, I've been waiting here for an hour. Why did that person come in? And as you had said, if it's chest pains, yeah, we got to take care of that. Is that a true statement there?
Yes, absolutely. I mean, that's what triage is for. So when you walk into the ER, the first thing that's going to happen is someone's going to ask you, that's another thing I should say, be prepared to repeat yourself a million times and try not to get frustrated by that, because the staff in the ER, we don't get to like sit down and have a debrief and talk to each other about everything that's going on. Like you may tell something to somebody and it doesn't get told to anyone else. That's normal because we're all doing lots of different things at the same time. So but when you walk in, someone's going to talk to you about why you're there. They're going to ask you what your chief complaint is. That's what we call it. What's the reason that you're coming into the ER? And they're going to check your vital signs. If someone has abnormal vital signs, they're going to get seen faster, especially if their heart rate's high, if their oxygen level's low, if their blood pressure is low or really high and they're having concerning symptoms, they're going to get seen faster. And if their chief complaint is concerning, so like, and time sensitive. So chest pain is time sensitive. We need to do an EKG very quickly to see whether or not someone's having a heart attack. Most of the time they're not having a heart attack, but we have to check, right? And then stroke, that's the other thing, is super time sensitive. When people have even minor symptoms and very like vague symptoms, they could still be having a stroke, and we need to act on that very quickly. So they will jump the line. And I'll also tell you, people who are younger, people who have less medical history, they oftentimes are going to wait longer. And so that sometimes it is appropriate to go to urgent care. I did want to add just one more thing about the ER is not a good place to figure out if something's been going on for a long time, like months. We are not well equipped to diagnose like a chronic disease. We are there to basically go, are you sick enough that you need to be hospitalized? Do you need surgery? Do you have a life-threatening infection? Those are like kind of the big categories I try to tell people about. So if you've had, chronic abdominal pain for like 6 months and you come into the ER expecting to get a diagnosis, you're likely not to, because if you've seen a bunch of doctors outside of the hospital, we don't run as many tests as other physicians can. So that is something else that I wanted to mention.
Okay. I think these are great guidelines. They're common sense, but what we realize is that when these things happen to us, the common sense sometimes goes out the window. On that last example that you brought up, I hear, we hear the headlines in the news about, a percentage of the country's primary care physician is the emergency room. From your perspective, how often are you seeing people that don't have the benefit of seeing a doctor and they basically wait 6 months and then they arrive on your doorstep looking for that diagnosis?
Pretty often, and not as bad where I work. I mean, a lot of our patients have insurance and have resources, but we do have a lot of people who are immigrants to our country that don't have healthcare resources. We have a very high Latino population in our area, and they oftentimes don't have access to healthcare. So I do see them for minor complaints for chronic conditions like high blood pressure and diagnosis of diabetes. And we do the best we can to kind of fill in the gaps, but we are not good at managing chronic diseases because we have no follow-up ability. So it is common that we see people for also for not being able to get in to see their doctor. So not being able to get an appointment, we see people for that. We also see people who have been waiting to see a specialist who now are kind of at their wits' end because they can't get an appointment with a specialist. So that's pretty common as well.
Right.
You see all the holes in healthcare in the emergency department, which is another reason why I've gotten into this space, because I feel like I can impact people more. Sometimes I feel honestly like I could make more of an impact outside of the emergency department than I can in there.
I love it. And this is a great segue to the service that you're providing and where we're going to kind of move the discussion next. But I want to Irene has a good question here. I'd love your feedback on this. And she says that she's used a couple of hospitals. I'm not going to name their names for a reason I'm going to share in a moment. But she's used a couple of hospitals in suburban Maryland and DC, emergency rooms several times, and both were terrible, giving wrong diagnosis and botched treatments. Is there an organization that rates hospitals, specifically emergency services? And well, Brittany, share your thoughts on this. I've got some thoughts that I want to share on this as well.
Yeah, I mean, it's really challenging. I think that it is easy to get a misdiagnosis in the emergency department. I think that we're really there to try to find life-threatening illnesses, and if people need to be hospitalized, and we do make mistakes. I mean, we're not perfect, right? We're doing a lot and seeing a lot of patients, and so we do the best we can with the resources that we have. I hate hearing that, because I truly believe that the majority of people that are working in ERs are there to make a difference and because they want to help people. I do think that it's a stressful job and people do get burnt out by it. And so sometimes they could be having a bad day and be more likely to make a mistake. I don't know of, I mean, that's a great question about looking at rankings. I don't know that that exists. I do know that there's a organization, or I don't know if it's an organization, but it's something called Press Ganey, and it's patient satisfaction, and our ERs get ranked based on that. And so I do know that that exists, but I don't know if that's data that's public or not.
And really the thing that I wanted to kind of throw on the pile here for Irene, and it's horrible that she had these experiences at two emergency rooms. The thing about rating systems, and this is for everything, folks, is that, a rating system is generally measuring satisfaction, based on surveys, people willing to fill it out, or an inspector comes in on a given day. Your experience on Sunday night, with two overworked doctors and skeleton staff might be different than if you arrived at, on Thursday in midday. And the nature of your injury or why you're in there is different. And so I think one of the best things is digesting some of the things that Dr. Lamb is going to share with us here. For us, we can only control what we're in control of. And if we can go in armed with the right information and say the right things and be prepared, that would be great. And, when you talked about Janet says in chat here, Dr. Lamb, that's exactly how I feel as an RN who worked in a hospital setting and with the insurance industry. I feel I can have more impact educating about how to navigate the healthcare system. And I think that's what's so noble and interesting about what you're doing is that it's kind of like when you're scrambling around taking care of patients in the ER, there's only so much you can do. I mean, but when you're not working, if you can create forums and discussions like this so that when we all go to the emergency room, we're your ideal client, that is good. So let's dive into Well, first off, oh, go ahead.
Can I
Yeah.
say something real quick? I did want to say that in regards to seniors and aging, there is a push, and this is coming, that we're going to have more geriatric emergency departments getting accredited for geriatric care and geriatric specific emergency departments. I'm super excited about this. I'm not a geriatrician, right? I'm an ER doctor, but over half my patients are over 65. I mean, a huge number of the patients that I see are over 80. So I know how to take care of sick older folks. That's what I do. I mean, the majority of the patients that I see that are critically ill are older, sorry. And oh, look,
Yeah,
yes,
somebody
yeah,
dropped this into chat. This
yeah.
is it's in chat there, everybody. You can get to this website. This is a geriatric emergency department accreditation program.
Yeah, the
Um,
American College of Emergency Physicians is really pushing this because I mean we all know, everyone who works in aging care and the senior facing industries, we all know that our population is getting older and we need a solution for this problem because the care of folks who are older is way more complicated. And so we need ERs that are better equipped to take care of them. It just takes time. And it's also, there's barriers with the healthcare systems, insurance companies paying for all this and logistics. So
um, let's see, Dixie, who's always has great comments in chat, says, do you feel that the homebound care movement, meaning taking care of people aging in place
aging in
versus moving somewhere for seniors, helps reduce the need for ER visits?
um, well, everyone as they get older is likely going to have to come to the ER at some point. So I think having a plan to safely age in place 100% can decrease visits. But I also think we know that people have issues that, I mean, maybe that will help decrease risk of falling. That will help them get better hooked up to resources and care so that they can prevent things. And I think that's wonderful. But people have underlying diseases, COPD, heart failure, kidney disease, and these things get worse over time, and so it is likely people will still need to come in. But yeah, I hope that helps. The other thing is medications. So taking a look at medications and making sure people are not on too many, they're not being overprescribed, and medications have a plan. Like, medications need their own plan. So as people's day-to-day habits change, say someone gets a bug, like a GI bug, okay, and they're vomiting and having diarrhea, and then they're still taking all their blood pressure medications, that's a huge issue. And so if people can plan for things like this, and if aging in place allows for planning, then yes, I mean, I think we can decrease a lot of need for hospitalization.
Um, John Shoemaker is the community member that shared the other slide, and he also shared us this with him, with everybody, the Geriatric Emergency Department Collaborative. So these are some pretty cool resources here, and as you can see,
Yeah.
they've got a bunch of hospitals here in the States that are part of this. So thanks so much, John, for sharing that with our discussion today. And let's see, okay, so
Yes.
let's dive into now the other thing. I know that we mentioned that you're trying to help people outside of the emergency room navigate it, and you've chosen to start with helping people with dementia. But I don't want anybody on this discussion to think that this is exclusively for people with dementia, because quite frankly, the tips and the things that you're going to share with us are going to be helpful if you've got a 5-year-old who's going to the emergency room. But your service and the families that you're working with one-on-one and teaching are those with dementia, because you can see where this can be a long-term thing, and over the span of dealing with the dementia related illness, there could be multiple trips to the hospital. Is that a fair assessment?
Yeah, 100%. It's all about learning what you don't know, filling the gaps in your knowledge, having a plan so that when you do wind up having to come to the hospital, you're not like deer in headlights. you're more informed when you're making decisions, because I educate people on a process that they can take to make their own medical care plan. They can work with me as individuals, but then I also have a course that they can go through. And I want people to understand the actual, in layman's terms, like understand why these diseases happen, how we diagnose them, what they look like when people become really sick from them, critically ill is the term that we use, and then how those treatments actually look on a logistical level. Like if people don't understand the treatments that we're doing, they can't really make informed choices. And so that's what I'm teaching in my services.
Great. Well, and I'm going to share your website in chat there so that everybody can log in and check that out and choose to join your classes and what have you. But
Yeah.
what are some sort of, if we're all listening to this today, like what are some things that we can do to be that ideal patient walking into the emergency room?
Yeah, so there's a few things. I kind of jotted down some things for you all. I mean, I kind of set up initially like your expectations I talked about earlier. Know that your day is going to just be sucked away probably. You're probably going to be in the ER for 6 hours, maybe 8 hours. It just depends on how busy it is. If you're bored, that is good and reassuring. I've started over the past several years. I'm like, boring is good whenever I leave my patient's rooms. And just sit here and be bored. If there are a bunch of people around you, you should be concerned. Like that's not good when there's a lot of people in your room. So those are kind of the expectations. I say when you come to the ER, if it's actually a choice, because sometimes we have emergencies and we have to call 911, and then we're just brought in and it's obvious, like we're having chest pain, we can't breathe, we can't stop vomiting, we have a severe headache, and now we're confused. I'm not talking about that. I'm talking about if you choose to come in, have a goal in mind, like have a question that you're looking to have answered, have some expectations for what you want to happen, and just communicate that with us. Like, what are you concerned about? I tell this to the nurses that I actually work. We have a lot of new nursing staff all over the country. We have this nursing turnover issue. COVID, I could talk about this for a long time, but when I teach people that are coming into the ER, I tell them the patients, if you listen to them, they will tell you what is wrong with them. And if they can't tell you what is wrong with them, they'll tell you what they're worried about. And what they're worried about is what we need to address on this visit. So for me, I want to know what it is that you're concerned about and what your goal is in coming to see me, because then we're communicating, right? Then we're not leaving things on the table. You're not like, I was really worried I was having appendicitis and the doctor never even mentioned it. Just tell us, be open with us. So those are things I would say have an expectation. For seniors, I would say it's really important to have paperwork if you need it. If someone is not able to make their own medical decisions, we would really benefit from having their medical power of attorney form. If they've been able to do that, it would be helpful to know who their medical decision maker is, who's making their care decisions. And I know there's logistical issues with this because sometimes people don't do this in advance. So they don't actually have that legal document that says I have the right to make this person's medical decisions. But as family, you have a legal right. And there's like state by state, there's a hierarchy of who has a legal right to make decisions for someone when they didn't declare a person legally on paper. So it's good for us to know, like, who do I need to talk to? Who do I need to talk to for this person? I would love to have their advance directives. If they've done any planning for what they care about regarding their healthcare decisions, I would like to have that. And nowadays you can actually proactively put this stuff on file at hospitals. And I would recommend that you do so. I would recommend that you look, and I don't know logistically how to do it, honestly, but we have a tab in our medical records. I can click on a button like on the main page of someone's chart and immediately see all their advanced directives or medical power of attorney. So it's better now. Like we have the ability to do this. So get it on file. Get it on file. And then the other thing I'll say, and then I'll let you take over, is for seniors, for aging folks, especially those who can't make their own medical decisions and someone's speaking on their behalf, we need to define someone's goals of care. And this is a topic that I teach I teach this online and I don't charge money for this because I'm so passionate about it. We have to know, and I'm not going to talk, I won't teach it here because it would take me too long, but basically when I talk about goals of care, it's in a nutshell, how aggressive does this person want their care to be? Are we doing everything? Are we doing some things, but not all things? Or are we focused on comfort care? And as we age, we need to have that goal before we come to the hospital. You cannot define this goal in the ER. It's incredibly challenging to do so. It's very time consuming, and people are so stressed out and emotional, which is reasonable, but it just doesn't work well in the ER. So we need to do this work ahead of time.
Wow. These are great suggestions that I've never really heard articulated that well, but it gets the wheels turning, and I hope it does with everybody in the audience. As Laura says, I worry that my DNR wish will not be honored in the ER if I have even mild dementia. Is there anything that I can do in advance? And that's,
Right.
because you're focusing here first on families with dementia.
Yeah.
um what are some thoughts on that?
Yeah. So I can tell you that I've seen lots of cases of people who have received, let me back up for a second. A do not resuscitate order form only applies when you don't have a pulse. Okay. So you can't feel your heartbeat and you're not breathing. So the person is either dead or they are actively dying in order for a DNR to go into effect. And that's when we would start chest compressions and we would start doing stuff to help someone with the breathing. We give them medications. We maybe would shock them, but we don't always shock them. People think that we can shock everyone and we can't. So that's when a DNR goes into effect. So it is a helpful document to have, but only in that case. And so I do find a lot of people thinking that if they have a do not resuscitate order, that means that they will not receive other critical care and other life prolonging treatments. And that's a misconception. There's also a misconception that if you have a do not resuscitate, you won't receive any care. And that's also not true. There is healthcare worker bias towards people who have do not resuscitate order forms. We do know that they tend to get less care, and oftentimes that is appropriate. But as a caregiver or as someone speaking on behalf of someone else, you do need to realize that if your person has a do not resuscitate order, it only goes into effect when they're dying or have died. So if that form is not physically present, you will get CPR and you potentially will get put on a ventilator or intubated, I'm sorry, because the ventilator is in the hospital. Intubation is the procedure to put the tube down your airway and breathe for you with the bag outside of the hospital. So that will happen to you if you do not have that form. So if you have a do not resuscitate order form, it needs to be everywhere that you go, essentially. Because if you go to the mall and you go down and you don't have your DNR, and I'll tell you that if they may not look, like they may not look in your purse, maybe you don't have, maybe it's in your car. So it is possible that you would get resuscitation if no one's there with that paper. In the emergency department, if you have a do not resuscitate order form, get it on file with the hospital that you are most likely to go to. Get it on file and tell everybody. Tell everyone that your wish is that you do not have CPR and that you're not intubated if you are dying and don't have a pulse. Tell everyone, because then they'll be able to better advocate for you.
Yeah, and Dixie brings up, there's a famous case about the person that tattooed their DNR on their chest, and that might seem like a really good idea, but if you do the research on that, the state that they had, the state that they were in had a different requirement on DNR, and um, I don't know. Yeah, it's an interesting case. Actually, it would make a really great discussion. And here's the other point, because we went down this rabbit hole. Now, a lot of questions are coming
Oh
in
gosh.
about MOLST and POLST. Can you
Oh
give
yes.
sort of a just a broad overview of
Yes.
what MOLST and POLST is, and then
Yes.
actually, well, let's do that. And then Arlene has another question, and then we'll kind of dive into these.
Okay. Yeah. So just briefly, the Pulse program was started in Oregon. Basically, people there, I don't know the exact history of it, but people there realized that the do not resuscitate order only applies to the situation where someone is like actively dying. And there's a lot of other care that we do. And as people have severe disease, they have advanced aging, we know that a lot of times they don't want these other critical care measures. And so the pulse program and the pulse form was developed with those goals in mind, allowing people to identify more specific treatments that they wouldn't want as they have severe underlying disease or very advanced aging. So not every state has a pulse program. Like Florida doesn't have a legal pulse document. I actually did research when I was in medical school and wrote like a little paper about why we should make it legal in Florida, and it still isn't. But I do still recommend that people look at these forms because they can help you understand what treatments you may want to make decisions about. And I do actually, I'm a little bit biased. I do love the Maryland MOLST form. And the Maryland MOLST form has a lot of treatments on it that I think people should consider. Like it talks about the difference between intubation and then other things that we do when someone has respiratory failure, which is respiratory failure just means that your lungs have failed. And there are masks and other devices that we can use that are technically non-invasive because they're not going inside of your body. However, it can be very distressing and uncomfortable. And we really have to consider when we would want to use things like this. And specifically, I'm talking about high flow and BiPAP. So that form does talk about those things outside of someone losing their pulse and dying and having a cardiac arrest. That's what we call those things. But it also talks about dialysis and blood products and artificial nutrition, hydration. There's a lot of things on that form. That's one of my favorite forms that does exist from the from this effort. But I will tell you that there are situations in which someone may want critical care for one disease process, but not another. Like say someone has congestive heart failure. They may not want to have their life prolonged if their heart is failing. If they continue coming to the hospital for admissions because their heart is failing, they may want life prolonging or critical care if they have an infection and there's a high likelihood that they would recover and have a similar quality of life. And you can do the same treatments for these conditions, but in two different situations. In one situation, you would want it. In another situation, you wouldn't. And there's no way to put that on paper that I'm aware of. You have to do that planning and you have to communicate that plan with the people making medical decisions for you in order for that to be acted upon.
Okay. Wow, this is great. And I put the National Pulse link and the Maryland Pulse link into chat. And somebody had a question. They're finding it hard to download the chat. Don't worry about downloading the chat. I include that with the recording, and we'll have a podcast of this as well on our website. So if you go to our website, you'll see it this afternoon, and you can access all of this great content that's in chat here. I mean, it's hard to keep up with it now. Okay, Arlene says, how can we access the class that you're teaching for free so we can think about the questions you're passionate about? Let me go to your website. Hopefully everybody can see that there. So on your website here,
So if you go to services, then that tells you how to book a phone call with me. These are paid services. So I have phone calls, and then you can put your email in and get information about my course. It's not quite finished yet. The cost of that is $397, just being fully transparent. If you want to follow me on social media, I do a lot of teaching for free on Instagram. And then I also have a Facebook group that's free as well. It's a community. And I do a lot. I try to go live in there every week and talk about something. And I answer people's questions and oftentimes make a video based on people's questions. So the Facebook group is called Medical Decision Making. So that's my business page. All the stuff that I do on Instagram goes there. But medical decision making for your loved one with dementia, it's really kind of long. It started to come up when you were typing it in, but you have to type in the whole thing.
There. Okay. Well, I'll provide that link. I'll get it in there.
That's probably the best way to have one-on-one access to me for free and be able to ask me questions. The thing is that as a physician, if there's something that's very specific, I cannot answer it on social media. Like I have to have a conversation with someone, and I'm not acting as people's doctor in this situation. So it's all general information. And so sometimes when people ask me very specific questions, I tell them like, I can't speak to this through Facebook. You'll have to book a call with me. Um,
Okay.
so
So answer to Arlene is go to blambmd.com and you can contact Dr. Lamb and then figure out what course of action is the best. And then when you were talking about something, I think it was about DNR, Arlene said, is that true only in Virginia, Maryland, and DC, or in Maryland and DC? You talked about something that occurred in Virginia, and she was wondering, is it
mm,
Maryland and DC? I forgot, it was so long ago. Arlene, sorry, but you can reach out to Dr. Lamb on that specific question here. Okay, let's see. Let me go back to chat because there's a ton of stuff in here that
yeah, I'm going to scroll through it too, Steve.
Okay, cool. Okay, we did the homebound movement. I like your question about how we can be better patients in the ER. Doctors are only human, and we expect them to perform miracles 24/7, often on with little or no sleep.
Thank you for saying that.
Well, I remember, I will echo that, and I'm glad that you said we make mistakes because, I remember when my first child was born and the doctor went from a regular delivery to an emergency C-section, and I was sort of like, holy cow, this is somebody's job. I mean, like
Yeah,
I make mistake on spreadsheets all the time and I feel like it's life or death, but this is truly, you're making train decisions,
yeah,
but this is super challenging
yeah.
and every human body is different.
Yeah, I will tell you, I mean, there's so many instances where I have to deliver some terrible piece of news. I mean, I tell people they have cancer a lot. I find cancer in the ER. That like we were going back to reasons why people come in, they can't figure out what's going on, they can't access care. They come in and then I'm like, oh my gosh, you have lung cancer, you have pancreatic cancer, and then I go into a room and someone's mad because they were waiting 2 hours and they're hot, like hostile towards me, and I have to diffuse the situation, and it's challenging. We tell people their person just died and then go into another room and someone's there because they want a pregnancy test. And so it is a very challenging and stressful job. So I appreciate people like realizing, I mean, I'm just a human being, and we really, people go into this field because they care, and I think the field can make people kind of rotten, but that's not where we start from, and not everyone is like that. Like we all want to provide great care. It's just that there are a lot of pressures on us, and a lot of things can, if the like the cheese method, there's like this how errors occur in medicine and healthcare, the Swiss cheese method. And it's like if everything lines up in the wrong way, you can have an error, and that happens sometimes.
Yeah. And your point about the medical system, I think I talk about this almost every day to families is that I say to them, when they're frustrated at the assisted living or, the provider that it's like, I can't believe this. And I was like, look, the people that chose to take that job, I mean, I can say almost unequivocally, their heart is in the right place because they've got a lot of other career choices they can choose,
Mhm.
especially now. But the system and the process that we have to go through, whether it be, for insurance or for legal reasons or what have you, can oftentimes be very frustrating. And so I love the concept of you as a provider in your off time, sort of helping us be better consumers of this system. It's imagine if more of your colleagues did that, how much better the world could be.
I think it's coming. I think now that we have spaces like this and we can, like, I can make an online course and can teach people, what it looks like when someone with dementia has a urinary tract infection and they have to be admitted to the hospital, and all the things that they need to think about, the questions that they need to ask. And they can go listen to that whenever, so, I mean, and in full transparency, I know that the emergency department is not some place that I can work until I'm retirement age. I can't do it. And so this is me trying to create another lifestyle for myself, something on my own terms, kind of outside of the system. So, I am charging money for it because I can't do this. I cannot give all my free time away without
Well,
that.
also the value of somebody being trained by you and going into a medical facility is, I can tell you, is probably worthwhile. A lot of people on the call, I know they know her, Dr. Amy Schiffman. I introduced the two of you.
Oh, I know. I still haven't been able to talk to her.
Yeah, but you remind me so much of her, and I'm sure other people agree the same. Let's see. Tammy asks, do you think you could come out and do a physical presentation on what you offer and talk about this information to my independent seniors who live in an active adult community for people 65 and older? Tammy, definitely reach out to Dr. Lamb on using her website and her email, which I'll share. But do you do some live presentations when?
Yeah, I have a few. I have a few presentations that I offer. I've actually spoken at the Loudoun Area Agency on Aging, and I taught like 5 steps that you can take to become a more confident medical decision maker for someone with dementia, and some concrete tips for planning for an unexpected emergency.
Great.
It depends on the engagement, whether or not I would charge for that, but you can just reach out to me.
Got it. And then Dixie, again, who's a wealth of great topics. She says homebound seniors who receive medical care at home typically have been brought into the slow medicine concept, that avoiding ER visits and hospitalization is a priority. When you warrant homebound care, you likely don't want to extend your decline by over-treatment in tertiary care system.
Okay.
I've never heard of the slow medicine concept, Dixie. Definitely reach out to me because we should do a full discussion on that.
Yeah, that's a great idea. I
Um,
mean, when people are more towards end of life and their goal of care is comfort and they don't want treatments that would prolong their life, it often does make sense not to come to the hospital and to receive all that care in their home. So yeah, I mean, that makes sense to me.
and I know, you've been practicing in an ER for 5 years, but Kathleen says, thank goodness for the establishment of urgent care centers. I
Mhm.
think, prior to the establishment, and now there are private and nonprofit ones.
Mhm.
All these people were in the emergency room. So I imagine your lifestyle now compared to some of your colleagues who were practicing 20 years ago is probably a little bit better in terms of.
Well, I would say too, like, things have changed with documentation requirements. And so a long time ago, people used to use what we call T-sheets for documentation. It was so much easier to see patients because they would just circle things on paper, and the documentation and the record recording was not the same. So they could see a lot more patients. Now we have a lot more pressures from documentation. I mean, urgent cares are very helpful to offload, things that people would have to wait a long time to be seen in the emergency department. 100%.
And I will tell everybody to read Sue Maddox's comment, which is more around sort of staffing. And I like how she said the body filling gap that can sometimes dominate a healthcare community. And a lot of this comes into the way of culture and the leadership of whether it be an assisted living or a hospital system. The Okay, and then Kathleen has some. Okay, this is kind of interesting. I don't know if she needed a COVID test, and I looked online and I found the records with faked information as if I had a full medical exam. Was the doctor listing a visit that did not happen because it required him to do so? Huh. Okay.
So that does happen sometimes. So it looks like what she's saying is that the doctor came in and talked to her, but didn't actually examine her and then documented that they did. And I mean, you're not supposed to do that. Let's just be honest, like that's not supposed to happen. I will tell you that it's really easy to do so because when you're documenting, you can literally click a button and it fills all that in. So that could be very frustrating from a patient standpoint because it could affect your bill. And so you can absolutely say, nope, that didn't happen, and report that to the billing company or that, that facility. And they should speak to the doctor and make sure that they realize that they can't do that. And so what we do on physical exam, when we examine a patient, that's what's supposed to go in the record. We're not supposed to document things that we did not do. I mean, it's a strong word, but that's kind of fraudulent. So I don't know that that was their intention. You don't know what the person's intention was. It could have been a mistake if they were very busy.
Yeah, and I think, as we said, everybody makes mistakes, and I often, when I look at these, when I look at what you all are doing, in terms of meeting with the patients, documenting it online, and this, that, and the other. I mean, there's a lot of. It would be very easy to press the wrong button, and
I guarantee you, I've done it. Guaranteed.
Yeah.
I mean, I guarantee you that I've put that I, looked at someone's eye and I didn't look at their eye.
Yeah.
Because it's so, listen, I see 2 patients an hour and I have a lot of documentation that has to happen with that. And oftentimes we do it after. We're like not even doing it in real time because we're so busy that we can't. So, I mean, mistakes do happen in the medical record. And now people have access to this stuff. Before I think 2020, people didn't have access to their charts. So, we're gonna get better. Things will improve as there's more communication. But I do think that people should advocate for themselves and look at their records.
Mm-hmm. Okay, this is, I don't know if you can help with this, but again, Dixie, you get the gold star today for all these great questions and thoughts. For ER patients who have high deductibles, I remember this when I had my kids in there. How can we help clinicians be more judicious about what diagnoses are essential and what's relevant information?
I think that's a great question. Because I think some of us are more sensitive to this than others. And I'll tell you that trying to save time in the emergency department, oftentimes people will have orders put in before anyone ever goes to see them. So that is something you all should be aware of. Like there's protocols that get ordered based on someone's chief complaint. So the reason that they're there, say they have abdominal pain, there's a set of labs that we order pretty much on everyone who comes in with abdominal pain. So if you're coming into the emergency department and you're concerned about finances and resources, it depends on how sick you are. If you're super sick and you're vomiting everywhere, they're going to put an IV in you and get blood work, and they're going to give you fluids and medications and all that. But if there's more time to think and be thoughtful, I would just be very kind to the staff and say, I'm very concerned about cost, and I would prefer not to have any testing done until I see my provider. And be very nice about it, because a lot of times the staff is going to get reprimanded by not collecting those labs, because it's so routine for us to do on pretty much on like almost every patient that comes into the ER is going to get labs. I love not having to do blood work if it's an option, and I often stop people from doing that when it's not busy and I see them going into a room. I'm like, wait a minute, let me go in there first. But just know that does happen. So just say you're worried about cost. Just be upfront. That's part of that communication and being open and talking about what your expectation is and what you're worried about.
Great. And let's see, oh shoot, I had a good one here. Okay. Okay, Sue says, on a daily basis, I help families and patients access palliative care and hospice care in situations where people keep going to the ER, and with this care, they stop going to the ER and have an excellent continuing care experience. Okay. Yes, great. I think there's a lot of providers out there that, prior to working with a home care provider or care manager, we can disrupt this
Cycle.
habitual visits to the ER. Very
Yeah,
good point.
100%. And I think, she's saying too, if only more ER staff, case management would broach this care choice. And I'll tell you one barrier that I see to that, and I think it's time. I think that it's a lack of time. And it's these conversations are challenging to have in emergency departments. I like having them. It's kind of my passion. So I do this all the time. I talk to people like a broken record about palliative care and hospice care, and how you can stay home and receive care that's covered by Medicare, especially with these services. But I just think that I think the barrier is the logistics of running a busy emergency department, having to see a ton of patients, and the fact that this is time consuming, which is why people need more education about this, and we should we should do more planning in advance. So
Okay. Well, and I just looked at the clock. It's like it's already been an hour, and
okay.
somebody said we could talk about this all day, but this is great. One question from Tammy: what city are you in? You practice at an ER in Ashburn, Virginia, but where do you want to share what county you live in,
Yeah,
or
I live in Fairfax County,
okay?
and I work in Loudoun County. So I work in the freestanding ERs in Leesburg and Ashburn, and then the main hospital, Loudoun Hospital.
Great. And we're getting an audience all over the country now. I saw somebody's from Manhattan, so these counties probably sound foreign, but the the information and the community, it's all the same. So many people are saying excellent presentation, and I totally agree. I am delighted that our paths have crossed. And would welcome you on any time you want to share or partner or what have you. I want to remind everybody in the audience that we will be. This is recorded. It'll be up later this afternoon. I'll have all the chat there. I'll have Dr. Lamb's content and everything like that. And Tammy's in Atlanta, so when she reaches out, she'd like you to do a virtual presentation. And let's see,
Okay.
this always happens when I say it's going to be over, so let's make this our last thing. Do you or another organization provide education to physicians on when to send their patients to an ER? I've had several situations where a specialist has not looked at test results for 2 weeks, then checks these at 4 p.m. on Friday and sends the person to the ER. And the
Yeah.
patient is sent home from the ER and told to see a specialist. That does sound pretty common. I think I've heard that story as well.
This is honestly, it's hard to speak to that. I don't do that type of training. I think that a lot of physicians practice medicine a little bit defensively. And so if they see a concerning abnormal lab, they want that patient to get care. And if it's 4 p.m. on a Friday, they're only going to get care in an urgent care or an emergency department. And so, they may just want someone to look at the patient. I hear you. I see that all the time. And that's part of the reason why I'm a little bit burnt out. So
Yeah.
I don't know that there's a great fix to educating physicians on that. Eventually maybe, but they all practice, they're practicing independently and they're doing what they think is best. And yes, they may be misinformed, but also it's hard to reach back out to them. I will tell you that we try to call the specialists that send patients to us. We do try to close the loop and communicate with them when we can, but it's not always possible.
Yeah, and last week we had a discussion with a patient advocate, which is a little
Oh
known
yeah.
profession, and having a patient advocate in your back pocket can be a great person, another team member that
Yeah.
could minimize something like that,
Yeah.
or at
And
least help you.
you all are in control of your health care. And that's something that I think people they're worried that if they don't do what the doctor says, and to some extent, yeah, you're taking on some risk. But you are in control of your own healthcare. And if you're making decisions for someone else, you're in control. So that's why being educated and having a plan can help in these situations where, someone's telling you to do something and you're like, well, that's not within our goals of care. That's not what we're trying to accomplish here. So I don't really want to do that. And this is why, it, I think we all need to step up a bit as patients and advocate for ourselves, advocate for the people that we care about. So I love patient advocates. I truly believe that people would benefit, everyone coming into an ER would benefit from having a patient advocate, because you're having your worst day. So, you know, you need someone there to have your back.
Great.
Anyway,
All right.
thank
All
you for
right.
having me, Steve. I
Oh,
appreciate
this
you.
is my pleasure. And again, Dr. Lamb, you were fantastic. And I have to say, our community members, our audience, these are unbelievable questions. And like I said, I just love uh, hearing our panel members react to the things that you want to know. This is not somebody preaching to you. This is you giving us feedback and sort of saying, "Hey, tell me about this." And thank you so much for that. And I hope you all jump on the discussion tomorrow for talking where we're talking about older drivers. But Dr. Lamb, thanks again, and we will be seeing you out there.
Thank you. Bye, everybody.